We're supposed to have general disclosures, and so this educational activity is supported by a grant from the National Institute of Nursing Research through R.D. Doornbos and also through the IRLA opioid REMS program mandated by the FDA. And that's it, and then some consulting I've done also for Janssen and Relevant. So while I was preparing this talk the first time a few years ago, I did find the ultimate anxiety relief, which is scientifically blended, super effective anxiety remedy. And so that's it. That's the treatment right there.
Good.
We're done.
We all go home early.
Do we have any cases? So there, just the way that people have really looked for the perfect pain treatment and failed. Same with anxiety. It's not been possible to find the perfect thing, particularly on a chronic basis. A lot of our treatments that appear quite effective into the short term end up being damaging in the long term. So we'll talk about some of that. So I'm going to talk about epidemiology and then evidence-based pharmacotherapies and psychotherapies. One thing that's important to distinguish is between the symptom of anxiety and anxiety disorders. Anxiety is normal, ubiquitous, helpful. We need it to be able to negotiate the social and physical environment in which we live. And it's important to distinguish anxiety in acute pain, which is common but quite responsive to pain relief, and to reassurance, things that are not always available in the case of chronic pain. Anxiety disorders are common in people with chronic pain, maybe 2 to 3 times more likely in the general group. And then, for example, if you focus on subpopulations like women with fibromyalgia, you get a 4 to 5 times increase in the prevalence of lifetime PTSD, OCD, and generalized anxiety disorder. So the anxiety disorders differ from the symptom of anxiety in that they're persistent, they're not responsive to reassurance or to pain relief, and they're clearly associated with worse outcome of chronic pain disorders and treatments. So there's been many different models about how anxiety and pain feed off each other. This is one that was put out by Asmundsen back in 2008. And they postulate that there's maybe as many as 3 things that get started. Some sort of psychological vulnerability, high injury sensitivity, high anxiety sensitivity, some sort of life event, and this could be physically traumatic or psychologically traumatic or often both. And then usually some high level of arousal or low threshold for alarm ends up producing an overwhelming emotional response and a cascade of other responses involving both autonomic activation, avoidance of situations perceived as negative, and then hypervigilance and cognitive biases where things that wouldn't otherwise seem threatening do seem threatening. And this ends up with somebody being disabled, either a specific disability or general, and this tends to feed back on the process. So both the anxiety and the chronic pain, in this case the anxiety disorder we're looking at as PTSD, are characterized by a lot of fears and monitoring, hypervigilance toward threatening stimuli, including pain and anything that causes pain, heightened startle response, and emotional numbing, avoidance, and dysregulation of stress response. So just like depression and pain feed off each other, so do anxiety and pain. So I'm going to talk about a number of the most common anxiety disorder types. First and foremost is post-traumatic stress disorder, which specifies that it has to occur after an exposure to an overwhelming event. And then people will have persistent re-experiencing of the trauma through nightmares, flashbacks, recurring thoughts, persistent avoidance of reminders of the trauma. They won't drive a car, they won't go to the hospital, they won't visit a doctor. Something that reminds them of the previous trauma. They'll try to not have to relive it by avoiding the reminders. But they'll often have increased arousal anyway, meaning that as I often say to my patients, their fight or flight alarm is kind of permanently turned on. They'll be easily startled. They'll have a lot of insomnia, irritability, anger. And then in addition, they really shut down emotionally. They back off from intimate relationships. Any kind of closeness with other people is too threatening, and so they just don't do it. Panic disorder is another specific anxiety disorder characterized by panic attacks with persistent concern of having more panic attacks or behavioral change like staying home to avoid panic attacks, which is called agoraphobia. And so this is discrete, unprovoked, rapidly escalating attacks of anxiety. There's a cognitive component that usually involves catastrophic thoughts like fears of dying, completely losing control or going crazy, and then a whole host of autonomic physical symptoms like shaking, sweating, nausea, chest pain, dizziness, numbness, shortness of breath, headache, abdominal pain. All these physical symptoms can drive extensive and expensive health care consumption in the emergency room, in various neurology, etc. clinics before people get onto the fact that someone is having panic attacks. So a little less prominent in the chronic pain population, but important anyway, are obsessive compulsive disorder. And I think one thing to learn about this is it's not just people who are neat or like to be on time or are careful about their work. There is a personality trait that's obsessive compulsive where people are very diligent, but this has to do with what are called true obsessions and true compulsions. So both the obsessions and the compulsions are experienced as kind of foreign and imposed. So people will kind of be tormented by recurrent fears of worst-case scenarios. They'll think they're going to make a terrible mistake and forget to lock the house or forget to turn off an appliance or lose control in some kind of way and hurt people. These are very difficult to resist, but they're not experienced as arising from the self. Same with the compulsions, like repetitive behaviors of hand-washing, counting, hoarding, checking, which are aimed at preventing a dreaded event or the associated distress. And the interesting thing is that even the patient themselves, and this is clearly in opposition to like, oh, everybody I know is obsessive-compulsive, the patient themselves almost always reports that these obsessions and compulsions feel excessive and unreasonable. And then probably the most common kind of anxiety disorder that in the general population is generalized anxiety disorder. Some people think this kind of continuous, widespread, generalized anxiety is not really different than low-level depression. And the genetics and the epidemiology suggests that it's true, that people who tend to have low-level depression also report a lot of anxiety. But this one is defined by excessive, difficult-to-control worry on most days for at least 6 months, associated with a bunch of autonomic symptoms: restlessness, fatigue, difficulty concentrating, irritability, tension, sleep disturbance. And it has to cause significant dysfunction in social, occupational, or other domains. So, let me jump right in from the epidemiology, or at least a description of the disorders, to a bit of more detail on medications for anxiety. This particular guy is afraid to take medications for anxiety, and there is some good reason for that, because the medications that are most effective initially, namely the benzodiazepines, are not very good long-term. So, are benzodiazepines a godsend or a curse? Well, they're both. Benzodiazepines replaced barbiturates because they're much safer. I mean, there is really no reason to use barbiturates for anxiety anymore. There's a much bigger therapeutic index for the benzos, which tend to prolong rather than intensify the GABA response. So the benzo era started with the release of Librium, or chlordiazepoxide, in 1960. The more famous cousin Valium, or diazepam, was released in 1963. And it's important to remember that between 1969 and 1982, throughout the entire decade of the 70s, Valium was the most prescribed drug in America. And it's interesting to contrast that with the recent decade. And the most commonly prescribed drug in America was what? Hydrocodone, Vicodin. So we've advanced quite a bit from Valium to Vicodin. A little bit further down the alphabet, but not far. So like the opioids, the benzos are quite effective and safe in the short term with rapid onset and good tolerability. They have a tremendous appeal to patients because they provide really immediate and relatively clean relief in the short term. But it is really important to remember that the benzodiazepines have no antidepressant action. And using them in patients with depression can be dangerous because people can become quite dangerously hopeless and suicidal under benzodiazepines, but they won't look agitated, they won't look anxious because that's been suppressed. It's also true that the benzos are not effective in PTSD and may cause harm. They don't work in OCD. They don't work for long-term in GAD. Alprazolam, or Xanax, which was heavily marketed in the 80s, did get FDA approval for panic disorder at that time, but it has pretty poor long-term results. So what are the benzos approved for? They're approved for short-term treatment of insomnia, but you and I know quite well that people who take benzos for insomnia, very few of them take it for a month. But it tends to lose its efficacy at that point. We are in an era where there's much wider use of what are called the Z-drug partial agonists. So these are kind of tailor-made, more specific partial agonists like the benzos. And this means zolpidem, which is Ambien, or azopiclone, which is Lunesta. And they've been tested a little bit longer, up to 6 months. Although there are some studies that suggest that beyond a month, they also don't really beat placebo. Long-term benzodiazepine use is associated with a lot of bad things. For a long time, we've known it's associated with amnesia. It's very impairing to memory, concentration, learning and motor impairment, increases rates of motor vehicle accidents, falls and fractures. And recently, it's been shown that not just during administration of the benzos, but over the long term, benzodiazepines do increase the risk of dementia. And I have found that's a pretty compelling thing to mention to your patients, that I don't want to leave you on these drugs because this increases your risk of Alzheimer's disease. People are so afraid of Alzheimer's, they're much more willing to get off at that point. So, but the fact is, benzos are popular. Recent study showed that about 5% of U.S. adults use benzodiazepines, and they're twice as common in women as in men. And both the use and the negative effects of use increase with age. You can see this little table from a recent paper that was in JAMA by Mark Olfson. In the 18 to 35 age group, about 2.6% of the population use benzos. But by the time you get up to 65 to 80 years old, it's 8.7%. And of that group, so it's only about 15% of users at 18 to 35 use them long term. But by the time you get older, that's doubled, so over 30% of users in the older age group are chronic users. And it's been specifically recommended by the American Geriatric Society that we avoid benzodiazepine use in older adults because there's so many negative effects. So, what about benzos and opioids? It's known that 80% of unintentional opioid overdose deaths may involve benzos, or benzo-like substances like alcohol, which also interacts with the GABA receptor. A recent paper I wrote a commentary for said that, basic opioid prescribing has probably peaked nationally over the past few years, but co-prescribing of opioids and benzos has not peaked yet. And in fact, benzo prescribing is more common, not less, when opioids are prescribed. So we know that benzodiazepines and opioids increase the risk of respiratory arrest or depression and is recommended against, but in fact, benzo prescribing is 3 times more likely in acute pain visits. It occurs in 8% of those visits. And it's 4 times more likely in chronic pain visits, where it occurs in 15% of those visits. If you expand your definition of sedatives beyond benzos to include muscle relaxants, which are essentially sedatives, and other sedating medications, we're really high, meaning a third of all acute pain visits include some kind of sedative along with an opioid. Over a third, 36%, include a chronic pain visit. At a chronic pain visit, include both an opioid and a sedative. And so in those chronic pain visits, if you get an opioid and a sedative, 39% got a benzo, 7% got a Z drug, but 73% got a muscle relaxant. And that could be the either carisoprodol or Soma, or the less potent Robaxin or Flexeril. But they all have a potential of interacting with opioids to increase respiratory risk. So, when we go to the most prevalent anxiety disorders, panic disorder and GAD, it's very clear that neither the Americans nor the British recommend benzos as first-line treatment. Both the American Psychiatric Association and the National Institute for Health and Clinical Excellence in the UK recommend SSRIs, meaning Prozac, Celexa, Paxil, Zoloft, Lexapro, not benzos as first-line treatment for these disorders. They do allow use of benzos acutely because they do have a very more rapid effect than the SSRIs, though they suggest not using it more than 2 to 4 weeks. Like opioids, benzodiazepines can cause physical dependency and be difficult to discontinue. They are associated with a whole host of negative effects like sedation, fatigue, ataxia, slurred speech, memory impairment, and weakness, especially in the elderly. The benzos are quite dangerous to drive with. Even people who are at stable benzo doses have impaired driving. And they do impair the motivation to engage in CBT and responsiveness to many behavioral therapies for anxiety. So, looking at national samples, and this NESARC study looked at almost 35,000 adults, they found, same as we do with the opioids, prescription of anxiety medication, specifically a controlled substance like the benzos, does increase the likelihood of lifetime non-medical use, 60%. Past year non-medical use, 90%, almost doubled it. And a lifetime abuse or dependence by over doubles it. And the group that is most likely to get into trouble with benzo prescriptions is like the picture here. Males, younger, white, history of use of illicit drugs or other drug use disorders, or other illegal behaviors. So it's important to recognize that our sense of what appropriate prescribing with benzos and other tranquilizers has shifted over time. I pulled this ad out of a 1960s medical journal, and it's for meprobamate, which we don't use anymore. Although we do use a prodrug because Soma or carisoprodol is converted into meprobamate. So it's amazing. Nobody would write for meparbamate anymore, but they still write for Soma. And it is this drug, and it used to be thought appropriate to prescribe it for mothers who had difficult toddlers. So, what do we know about opioids for anxiety disorders? I mean, opioids elevate mood in healthy subjects during acute use and make a lot of people feel better. And in fact, we know that the endogenous opioids mediate effects of GABA and the serotonergic drugs. Doctors were prescribing opioids for depression and anxiety as far back as Hippocrates and Galen. And in fact, the opioid treatment of melancholia and mania was very popular in the 19th and even into the 20th century in psychiatry textbooks. You have to remember that the opioids were one of the only psychoactive drugs known at that time. But I think that, and it's important to know that there are some people saying, well, wait, opioids work to treat anxiety and depression. But really, if you look at the studies, they're very poor quality. They're often small. They're either very brief or uncontrolled case series and not really to be given a lot of credence. To just give a sense of the fact that opioids are still being used, if not explicitly, at least de facto, as a treatment for anxiety disorders. I commend to you this study by Seal that appeared in JAMA in 2012, where she looked at 141,000 Iraq and Afghanistan veterans with a pain diagnosis. And she found that of the full group, 6% of those people with pain got opioids if they had no mental health diagnosis. If they had a non-PTSD mental health diagnosis, that doubled to 12%. If they had PTSD, it tripled to 18%. And not only were they more likely to get opioids, they were more likely to get higher dose opioids, multiple opioids, combined with sedative hypnotics, and to show worrisome behaviors like asking for early refills. Another study that we did at Group Health in Kaiser, we surveyed about 1,800 HMO members who were getting stable chronic opioid therapy. 29% said that they had used sedatives on at least half the days. And among the group with a substance use disorder history, it was nearly 40% who used sedatives. Interestingly, another 12 or 13% said that they had 2 alcoholic drinks within 2 hours of their opioid. I've had patients tell me, it works better that way, doc. Predictors of taking sedatives with the opioids included a substance use history. Females did that more often. People who were depressed. People had higher dose opioids for more than one pain condition. Actually, and it was just the males, really. Well, male gender was the only really strong predictor of concurrent alcohol. This concurrent use of CNS depressants with opioids was common in this population of stable chronic opioid users, regardless of whether they had ever had any substance use disorder. So what about antidepressants for anxiety disorders? They're the treatment of choice, but they're not always that easy to use for anxiety disorders because particularly initially, antidepressants can worsen anxiety. And that happens just with the cascade of effects from serotonin reuptake inhibition. You dump more serotonin onto all the serotonin receptors, and particularly the 5-HT2 autoreceptor can be anxiogenic. So, how do you work around that? The classic way to work around it is to start with a lower dose than you would start with if the patient was depressed. You know, not 20 of citalopram, but 5 or 10 milligrams. And after you have a week at that level, you can often get them up to a reasonable dose. You could use an additional antidepressant that tends to block that 5-HT2 anxiogenic receptor. Tricyclics do that, amitriptyline, nortriptyline. Other drugs do it, nifazodone, mirtazapine, trazodone. All those can be combined with the SSRIs or SNRIs to make them less anxiogenic. If a patient comes to you on benzos and you're trying to get them off, I always start the antidepressant before tapering the benzo because that protects against the anxiogenic effect of the antidepressant, and then you can taper the benzo later. And I rarely use benzos to help start patients on antidepressants because it's like pulling candy from a baby later, trying to get them off of it. So pardon the too much print on this, but I wanted to say that we have talked a fair bit about prazosin for PTSD here. This is a med that was kind of rediscovered at the Seattle VA by Murray Raskin and colleagues. It's a centrally acting alpha-1 receptor antagonist that is FDA approved for the treatment of hypertension. It was marketed as Minipress. It's now a generic that's cheap as dirt. And one problem with it being generic is there's no drug company pushing it for this new indication, nor will it ever have an official FDA indication for PTSD because there's no way for somebody to make money off of it. But prazosin has been proved effective in smallish RCTs. It's specifically effective for nightmares. That's where it's most efficacious. But also, to some degree, prazosin are hyperarousal symptoms as well. There's a big multi-site VA RCT underway. There are SSRIs that are FDA approved for PTSD, sertraline and paroxetine, but they're not so effective for the nighttime symptoms, might be poorly tolerated. They combine well with the prazosin. A lot of people find it very difficult to get patients with PTSD to sleep, and they have pulled out what many consider to be the ultimate weapon in that fight, which was quetiapine or Seroquel. Luckily, in a study, it was not randomized, but they did compare the prazosin to quetiapine, and prazosin had fewer discontinuations and better long-term effectiveness for those patients. So the way I use it is to start patients at 2 milligrams at bedtime. You got to warn them, particularly of the first night effect, where orthostatic hypotension can be quite dramatic and result in falls and fractures. So tell them to go to the bathroom before they go to bed, get up very slowly, dangle their feet. And we generally increase by 2 milligrams a week until nightmares cease, or up to about a maximum of 10. So I've talked about medications because the TelePain community is largely primary care and medical practitioners, but in most cases, the most effective and long-lasting treatments for anxiety are the psychotherapies rather than the pharmacotherapies. And these can vary from fairly simple things like relaxation training, including biofeedback, which just gives you some sort of visual or auditory signal that you're becoming more relaxed, to mindfulness techniques, which are essentially breath awareness techniques, self-hypnosis using pleasant imagery, up to more elaborate therapies like cognitive behavioral therapy, which has excellent evidence for effectiveness in panic, GAD, PTSD, OCD, and social. Another form of behavioral therapy that incorporates features of mindfulness is called acceptance and commitment therapy, also evidence-based. For people with PTSD, there are adaptations of CBT, trauma-focused therapy, or CPT is cognitive processing therapy. And then originally developed for chronically suicidal women or people with borderline personality disorder is dialectical behavior therapy. And all these therapies have the advantage of providing skill development and avoiding medication dependence and withdrawal problems. So there are a bit of limitations. In each case, It requires somebody skilled to do it. The CBT has been tested typically over 10 or more sessions. There are successful attempts to shorten up the course and to administer it by telephone or even by computer. So there are some forms that could be adapted to rural settings. Relaxation training is easily administered through tapes or CDs. One has to be careful that in severely traumatized patients to not provoke dissociation or psychosis. Trauma-focused therapy is highly effective but requires a skilled therapist because it can involve temporary worsening of symptoms. And then for many of our most difficult patients, I frequently recommend dialectical behavior therapy because it is a very structured, skill-building therapy, good for people who have pretty chaotic emotional and interpersonal lives. And that has been disseminated also kind of from Seattle because it was developed here by Marshall Linehan. But its most effective form requires a group and an individual session per week. And all these therapies are less effective when somebody taking benzos. So in conclusion, benzos are seductive but risky treatment for anxiety. They're seductive because they're quickly effective with few initial side effects, just like the opioids. But just like the opioids, the therapeutic effects lessen, the side effects increase over time. Amnesia, concentration, lethargy, dependence. We now know from multiple studies they increase the risk of Alzheimer's disease. They impede the effectiveness of the psychotherapies. They can be used temporarily, but then you face the difficult problem of getting people off. And antidepressants are almost the opposite, meaning that they can provide you long-lasting relief, but initially they're a little harder to start. So I think that's what I've got to say.
Well, thank you, Mark. Do we have any questions? We've certainly got time, since apparently, am I right, there are no cases submitted, so we have all sorts of time. Anybody?
One question coming up
right
directly.
Okay.
Let me ask you a question on patient satisfaction, because it is a trick when something works quickly. If they look at patients, 6 months down the road after antidepressant therapy, do they express high satisfaction and say this has been great treatment, or do we have data like that?
I think there are data like that. I don't know it.
Yeah.
I think that the benzos, I think in many ways they're like the opioids, meaning that up front they're very appealing, over time less so appealing. So a fair number of people will quit them rather than go on. But then there's a self-selected group that likes them chronically and will be convinced that they work because it made me feel better when I started. It makes me feel bad when I stop.
Right.
And in the middle, the fact that they're not doing very well somehow isn't that apparent to them, or they choose to ignore it.
I've always thought that benzos and opioids were the sort of, for the pain physician, opioids are the difficult one, and for psychiatry, benzos.
Yeah.
We've got a question here. Gloria, this is really great information, and I, for one...
Some questions on the wall. People type them in.
Okay.
Joe Yellen also has a question.
Okay. Well, let me just read this one. This is really great information, and I, for one, feel that too many patients are started on benzos, but I'm working with over 15 other providers who feel that prescribing them on a regular basis is okay. Makes it difficult when they see me and I try to get them off and trying them on other medications. I'm not clear who has to be convinced there.
Well, she's trying to get them off.
The providers, but is it the providers or the patients? I'm not clear who are... all right, how would you deal with it? I'm not sure whether they're dealing with the providers or dealing with the patients.
Well, both, because they both want the benzos.
Yeah.
So...
she says providers.
Yeah, okay. So I think that you have something new to say if the patient is also on opioids. And I would stress that the combination of benzos and opioids is quite dangerous, and they may not be tuned into that issue if they haven't thought of it before. You could say, this is a really strong reason to get the benzos down. I also, as I mentioned before, I think the fact that people get confused and fall down is old news, but you can remind them of that, particularly if it's an older person. And then I emphasize the risk for Alzheimer's a lot. I don't know that a lot of prescribers have kept up on the studies that have come out in the last year or two about that. And I would add to that as another reason to come off that they may not be aware of.
Good, finally.
Okay, now we've got another question. Could you speak to the use of beta blockers for anxiety?
Or should I answer the top of
What's that?
the Buspar one up above?
Oh, okay. All right. Then just one word, Buspar.
So Buspar was the brand name of buspirone, which is still available. It is a drug that was marketed for anxiety, but it's actually a serotonergic agent, much more similar to the antidepressants than to the benzos. It, as people have heard me say before, there was kind of a joke told around the mental health world about Buspar, which was the good news about Buspar is it doesn't have side effects, and the bad news is that it has no therapeutic effects either. However, Buspar, since it's gone off patent and is now a cheap generic drug, has had a bit of a renaissance. Not so much as a standalone anxiety drug, because it's very difficult to take a patient that's been on benzos and have them be satisfied on Buspar. It doesn't produce the same effect. And so people have found it difficult to use, and it doesn't have a lot of advantage in many ways over the SSRIs as a standalone anxiety treatment. But its second lease on life has come from the STAR-DEAST depression study, where they basically randomized people to a cascading set of treatments, because only a minority of depressed patients respond to any particular depression intervention. So it turned out that Buspar was, among others, an effective way to boost the effectiveness of antidepressants. So it's now used probably more commonly as an augmentation for antidepressants than as a standalone anxiety treatment. But it is important to remember that it is not addictive, it's not a controlled substance, and it has none of the same risks of the benzodiazepines, because think of it more as a serotonin. It's not an SSRI, but it's more of a serotonin drug than a benzodiazepine or a GABA drug.
Okay, and the next question. Could you speak to the use of beta blockers for anxiety/panic attacks?
So, beta blockers, as you well know, they control pulse rate, blood pressure, a fair number of components of autonomic arousal are suppressed or dampened by beta blockers. But as far as I know, the only data-based situation to use beta blockers for anxiety is performance anxiety. Like violinists or other performers will sometimes take some propranolol before they get on stage, and they won't be jittery on the stage the way they would be otherwise. For a more enduring or global anxiety problem, they don't work.
All right. Dr. Bergman on video has a question.
Okay.
Comment. Go, Rob.
You have a question?
Yeah, I do. Joel Yellen here. Hi. I can understand why the Beers folks said that we should not be using benzos in the elderly, because their job was to make sure to minimize side effects, pretty much exclusively. However, anxiety doesn't go away as you get older, and the SSRIs, which they would rather us use, have about a 40% success rate. So that leaves us basically with nothing. And I have a fair number of elderly patients. I try to keep the the benzo dose as low as I can on them. But frankly, if they've got anxiety and they don't respond to SSRIs or SNRIs, I pretty much need to go with that. Do I not? Keep them on some benzo, yeah?
Well, I commend you for working to get the doses down. I think that's important. Same as the recommendations we make here about opioids. Everything needs to be balanced in a cost-benefit kind of way. The rates of chronic use go up as people get older, even though the risks go up, partly because I'm sure you've experienced that. You see somebody comes into your office, they're 65, they've been on a benzo for a decade. It's really hard to get them off. It's almost hopeless to get them off. So we're not magical people, and I would work with the patient as best you can to minimize the risks that we know about them. And I think you're right, getting the dose down, getting concurrent opioids down. I would have frank discussion about the risks, and that's often the best you can do. It's not true that you can get everybody off. But I think the Beers thing was based on that they didn't see a really great risk-benefit ratio in these older folks. But I know I've seen a lot of these people that have no interest whatsoever in getting off.
Okay, thank you.
Regardless of what we say.
I wonder, Mark, just your thoughts. It seems to me that one of the things that we're coming to believe in the opioid world is don't start that path so rapidly. And I wonder if we could say the same about the benzos. We've gone through a generation where it was a very low threshold. The person is anxious, give them a benzo, and then you have the difficulty getting them off. And that as with opioids, maybe to have that not as your first line therapy, so there aren't as many people who are in this situation as saying, you've been on 10 years, I want to stay.
Well, let me just say that I think we get into long-term use without ever intending it. Same as with the opioids, meaning, if you're a primary care doc, a family doc out there, and somebody's got, some sort of relatively acute increase in anxiety, you can make them feel better really quickly with some benzos. But the problem is the back end, where all of a sudden what looked like an acute anxiety issue has now become a chronic anxiety issue, and you have to actually rethink what the appropriate therapies are and somehow convince the patient to come off a treatment that they now love because it's made them feel so much better. And then it's very difficult to get them off. So I think you're right. Yeah, just like in our more recent opioid guidelines, we've started to pay much more attention to the duration of the therapy and to not let it just go on and on. But once the therapy is established, whether it be benzos or opioids, the easiest thing to do is to always refill. Otherwise, you've got an argument on your hands. And, sometimes finding the alternative that's going to feel the same is not easy.
Yeah. Mark, this is Ron. I've got another question. This is kind of a loaded question. You can answer it if you like or not. What about medical marijuana as a useful drug for anxiety?
So, we're just beginning to learn about cannabinoid pharmacology, and there's so many different cannabinoids, all of which are of course mixed in the cannabis plants, and it's important to remember that marijuana can decrease anxiety and it can also increase anxiety. There's many patients and friends and ex-acquaintances who had their first panic attack on marijuana. It is unpredictable, I think, is the best way to say, in terms of its effect on anxiety. Supposedly, the indica strain is more sedating and soothing than the sativa strain, which is more activating. I don't know of any clearly controlled data suggesting that one's better for anxiety. I know that there's patients who say that they do get relief, but I don't think we have the data on it at this point.
Ron, I was asked to do a talk on cannabinoids by no other than Susie Rapp, who's sitting here. So I looked up literature this a year ago. And in the aggregate, there's a concern about the psychiatric adverse effects of cannabinoids. Now, that doesn't say that every psychiatric symptom is made better or worse, but that overall, the big downside of cannabinoids is adverse mental health effects. And this shows up particularly in young people, things like participation in school, success in the workforce, psychiatric hospitalization. It seems as though cannabinoids, on balance, are bad for mental health, especially in young people. It's not so clear in middle-aged and elderly people, but it's somehow, I think, if we just take one symptom, that may be difficult to assess. But if we say what is good for the mental health of our people, particularly in young people, I would say cannabinoids are a bad choice. Yeah, sure.
So I have a question, Mark. Now, in this era of not having good evidence about opioids, I have been recommending PRN opioids more than daily opioids because over and over again, I've had the tolerance factor come back at me over all these years. But what are your thoughts about maybe prescribing less of the benzodiazepine, and rather than, if there's an acute event, give them 10 tablets instead of 1 every day, and continuing on using it for the worst anxiety as some of us are shifting using the opioids for the worst pain. I think that's a shift, but I'm wondering what your thoughts are.
So, there are an amazing number of parallels with the opioid story. We went through a period, in fact, when I was training in the 80s, I think we were already shifting to the idea that benzos should be prescribed scheduled and not PRN. And so we saw a shift away from Xanax to clonazepam, for example. And I still see our residents doing that. I don't think that we have the clear data in the benzos we do in the opioids that, side effects are worse with more exposure. But I would imagine that these memory impairment, Alzheimer's risk type consequences of benzos are probably worse if you've got a continuous exposure rather than an intermittent exposure. Do we want to go back to PRN dosing? Because that was the old Mother's Little Helper Valium story in the 60s, is that you carry your pills with you and you pop them when you're, feeling overwhelmed. And I think in some cases the benzos are less good candidates for that than the opioids, because I think the important thing in this respect is that it impedes learning. You never kind of gain confidence about working in an anxiety-generating situation. You don't overcome fears or avoidance behaviors if you're taking a Xanax every time. But I have not seen a parallel to this shift from continuous to PRN opioids. It hasn't quite made it into the benzos, maybe because there was that long, bad news in the past about it.
I'd like to put in the vote on the other side, because speaking back when I was a psychologist in the 1970s, I was involved in the perception of control over aversive stimulation. That has an enormously powerful effect. Conversely, the lack of control makes any aversive stimulus infinitely more aversive. So that I think I would suggest that there is a parallel with the opioids if people can be judicious in their use. It seems to me the problem we get in with the opioids is that people say, but I hurt all the time. So every day is the worst day of my life. And if they do that with Xanax, then it's going to be every day I need Xanax. But the notion that people have occasional overwhelming anxiety that they can control with the benzo, it seems to me reasonable. I have to tell you my story, because when I was moonlighting as a medical, I didn't call myself a psychiatrist since I had completed my residency, but as a psychologist/physician, I had this one lady come in to me, and she said what she wanted is 1 2 milligram Valium tablet. I said, well, that's rather interesting. Why do you want 1 2 milligram Valium tablet? Turns out she had been incapacitated by a fear of driving. She was simply homebound. She then went to a doctor who prescribed Valium for her, and she said, oh my gosh, this solved my problem. I can go out and drive my car.
Except she's a much worse driver when she takes that.
No, wait. Then she found she did not have to take Valium.
Yeah.
As long as she kept a Valium tablet in her purse. She came to me because in the 2 years she's been doing that, never once consuming any Valium, her 1 Valium tablet had disintegrated. It was now powdered. And she wanted 1 more. So I give that as an example of a person where the perception that they have a solution used very, very judiciously, in this case, 0 times. There are people, I think, like that.
Well, yeah, in the 80s, we called that the Xanax in the pocket phenomenon.
Right. Yeah.
Which some people are able to kind of move, from actually using the Xanax to just having as in recourse. And they do somewhat improbably gain confidence and independence from the Xanax. It's very hard to tell who's going to go that way versus who is going to become more dependent on the medication. But I have heard of that happening, and
again, I think the analogy of opioids, again, the person who says, I always hurt 10 over 10, therefore I take it as needed, which is all the time, versus the person who says, I take an opioid once every 2 months or something like that. I think people are complicated. But let me go on to one other question. What about short-term antipsychotics to help benzo discontinuation?
Well, that's kind of going from the frying pan into the fire. I won't say I have never done that, but the antipsychotics, and I'm going to assume you mean the atypicals, which are the newer ones, have all of their own bad side effects. Not the same cognitive ataxia, forgetful side effects of the benzos, but different ones, lipids, obesity, etc. And plus, they're just nastier medicines in general. I have not really seen controlled data on this. I think I have indeed tried it, particularly with people who are having significant psychiatric problems, or even Haldol. Yeah. You can try. I mean, I'd be interested to hear your experience. I think that we went through a period of using carbamazepine for acute benzo withdrawal when people are coming off very rapidly. It protects against seizures and is probably mildly anxiogenic. So we have done it that way in the past. The antipsychotics have the advantage of not being reinforcing. Unlike the benzos, what I've heard people is like, if you're taking Haldol, you need Haldol. I mean, nobody takes it for fun. It is not a drug of abuse. And that being said, I had an old med school classmate who took Thorazine for fun. Very rare that people find antipsychotics to be abusable drugs. They don't induce euphoria. They don't do the same thing as the benzo. So in that respect, so should I answer?
Yes,
what about?
I want to say word on Haldol, because I did 2 years of psychiatric residency. We'd go to Harborview for coverage on call, and the patients would come in and you say your allergies number 1 Haldol, because they just hate it.
Yeah, it's not a real pleasant experience, I would say. I mean, it can be life-saving, it can be necessary, and people are willing to take it because it's better than not being on it for them, but it's not something that you would take to go to a party, that's for sure.
Okay, so Tom Harris, the palliative care community seems to favor Haldol for agitation.
Well, that's for a different reason. Agitation in the palliative care situation is often due to delirium, or what used to be called organic brain syndrome. and that is a global disruption in brain function where people are usually disoriented, and it's characterized by a global and comprehensive impairment in cortical function. So why do they use Haldol in that situation? Because Haldol does not further impair cognition. The benzos do. So if you give a benzo to a delirious patient, they will get worse. If you give Haldol to a delirious patient, it's not going to cure their delirium. That's going to pursue its own time course, but it will decrease the distress and the agitation of the delirious patient. That's why we use Haldol in delirious patients, because it has a primarily subcortical mechanism of action, and it doesn't further impair the orientation or the cognition of the delirious patient.
Okay, next we are firing up.
Good thing I'm going to be past my board exams here.
Well, with Grace, Joan has a case. It's great.
Yeah.
You've got so many questions here. What about hydroxyzine and gabapentin for anxiety?
So these are hydroxyzine and gabapentin are used commonly for anxiety. Hydroxyzine, it's an antihistamine, mildly sedating, has a ceiling effective dose. You can't really go beyond 100 milligrams. At high doses, it becomes agitating. At low doses, it can be mildly anxiogenic. I think if you have to avoid benzos, you need some sort of pill for someone to take to get them through a rough few hours, it can be fine. Gabapentin is an interesting drug that we widely suggest for neuropathic pain. It also has some popularity in anxiety treatment, particularly in personality disordered people that you want to avoid benzos, and it has shown some efficacy in that respect. I mean, I know people who've taken gabapentin that think it makes them high. It certainly is associated with some cognitive impairment, so it's not a drug with no side effects, but I do think it has reduced abuse potential compared to the benzos, and probably reduced but not zero cognitive problems. So I think it is a viable alternative for those people where you're not able to use antidepressants and you don't want to be using benzos. It can be used.
I'd like to say a word on gabapentin that I learned yesterday. Somebody reviewed literature, and since we talk about gabapentin all the time, saying that abrupt withdrawal of gabapentin can provoke seizures, and I was not aware of that. I think in my mind is almost never a case in a chronic pain patient to abruptly stop medications. But I think it just is interesting, and probably all of us who are using it should be tapering that medication down.
Yeah, and since I know Joe is trying to eat, but I want to ask Joe Merrill a question. I mean, Joe, do you see any abuse of gabapentin in your population? I've heard about it, but I don't know really how prevalent it is.
Yeah, that's the same with me. I've heard about it, but I can't say that I've seen it. There have been a few reports, and then the times I've heard about it have been like in sort of isolated, or certain communities seem to latch onto it. There was some tribe in Washington State that seemed to be happening, but it's not widespread. And there were some reports from back east, I think, as well. So some people do seem to at least be raising the question of whether it's more abusable than we thought, and I just can't say that I've seen it.
Okay. I did see a report, this is a little off topic, of increasing rates of tramadol abuse being presented to ERs. So now that we have more difficult access to hydrocodone, because it's now a Schedule II drug, I know in some systems of care there's been a big switch from hydrocodone to tramadol, which is easier to get, but there is an uptick in ER tramadol abuse now being reported.
Ron Bergman had another...
Thanks, Jim. Going backwards here, comment originally Susie made about the benzos, PRN. the payers have cut our use of Zolpidem or Ambien back, which is good. And what we generally prescribe now is only 10 tablets a month. And I find my experience has been that is working very well. Patients are very receptive of that. And I'll go one step further. What I'm doing is I'm having them cut the 10 tablets of Ambien down to half or a quarter, so they have enough. And also another comment was, if they have the Ambien present, this was a comment you had made, they're sometimes less likely to need it if they know it's available. And I have one other comment that I'm kind of, it works, but I don't know that it's entirely approved. I have them cut their Ambiens to about a third and go to bed, and if they wake up at night, they take 1/3, put it under their tongue, and it dissolves, and they're asleep in about 10 minutes. And it really, really works. So, so I've been very successful in getting through that. So your comments or thoughts, thanks.
So I mostly addressed Susie's question about intermittent use of benzos concerning anxiety treatment, where I think it has problems. But I think on the sleep or insomnia treatment line, I believe you that it's probably more effective there. And I also believe you that having it there often is enough for people to not need it, because they know they have a backup and they get less anxious about whether I'm going to get to sleep or not. I have not had patients use it under the tongue, but facilitates absorption. You know, that was the whole idea behind Sonata. You know, Wyeth marketed this very short half-life benzo-like drug at night called Sonata. It's a Z drug, to basically get that kind of instantaneous effect. Never sold that well, but I'm not surprised that you can get a good result that way.
Okay, well, have we run out of questions? This has been a very productive...
Did you have a case? I thought you were going to bring a case.
No, I think not. I don't know that it's so helpful for us to be presenting cases. So I'm going to pass on that. I think what we can do, unless there are more questions, is to basically get you back.
There's just one comment.
A comment. Wait, we have a comment. Whoa.
Comment from Gilda Mark, who is a psychiatric nurse practitioner at the Indian Health Service in Riverton, Wyoming. At the Wind River Indian Reservation, Wyoming, gabapentin, gabbies, are quite popular for abuse, as is Wellbutrin, Welbies.
Wow.
Gabbies and Welbies. There you go, Joe.
And but Wellbutrin, was that? That's
it is stimulating enough for people who like that. That I have heard of that. Yes, I mean. I don't know that there's any motion to make Wellbutrin a controlled substance, but it is a dopamine reuptake inhibitor. So whereas, cocaine and amphetamine kind of dump a lot of dopamine out, this slows reuptake. It's not the same thing, but if you're really hungry for dopamine, it might be something you want.
I think the appropriate is primarily, though, norepinephrine reuptake inhibitor. So I was saying you get an upper effect from that.
Dopamine is more tightly linked with reward systems, but who knows which it is. I have heard of it being abused, and so I'm not surprised that those drugs are mentioned